Good morning, everyone. Good morning, everyone. It's my pleasure this morning to introduce Kevin O'Brien, Professor of Medicine here at the University of Washington. I've known Kevin for years, and for years prior to me coming to the University of Washington, particularly through the Carmel meeting that he has been very active in and organizing. The reason I knew of Kevin was, I'll say there's, in terms of physician scientists, I think we're all focused on how we can translate what we do into improvements in patient care. And there's really, I would say, I'm going to split physician scientists into two big groups: those who sort of start with questions in the lab and then find ways to sort of apply them in the clinic. And then there are physician scientists who find clinical questions and then go back into the lab or use whatever tools they can find to sort of answer those questions. And one of the things that's always impressed me about Kevin's work is he has really used the clinics as a incubator to come up with novel and interesting questions that he has then gone and used array of different techniques to analyze. You can see from his CV that has well over 100 publications that he started in atherosclerosis and lipid research, translating things he was seeing in clinic into the lab and then back. He's also more recently had an interest in metabolics, in heart failure, that he's given grand rounds about previously and now holds NIH funding for. And then I think the COVID pandemic really is another example of him being able to see what's current and important, and then again focusing resources on that to answer interesting questions and improve healthcare. And so it's with great pleasure that I introduce him for his talk this morning, COVID-19, Getting to the End of the Tunnel.
Rob, thanks for that kind introduction. And I also have to say, I'm really grateful that you came to the University of Washington. You made a tremendous difference to our division. So here's the outline for the talk. I'll first review non-pharmacologic interventions for pandemic respiratory viral illnesses, particularly lessons from 1918. That'll also give me opportunities to show a few old slides from Seattle. Not slides from when I was here in Seattle, but nonetheless, have been here a long time. I'll then briefly review inpatient care of patients with COVID-19, predominantly drawing from the NIH guidelines, which are updated frequently. Also, briefly review some of the key factors for critical care of patients with COVID-19, and then try to summarize and conclude. So a couple of disclaimers. This talk is not a detailed literature review. It's intended to inform clinical decision-making should you care for COVID patients. And it's not intended to be a postmortem on factors outside our control. Here's a quote from Teddy Roosevelt that I've heard recently referred to as a perfect distillation of the Stoic philosophy. Do what you can with what you have where you are. And here's another quote that I like: if you're going through hell, keep going, from Winston Churchill. So just to frame why I wanted to talk about clinical care, inpatient care of COVID patients, here are the projections, the most recent projections from 2 weeks ago for deaths per day for the state of Washington on the left, which should peak at February 6th at around 65 per day. But on the right, to point out that by February 7th, the peak bed resource utilization will be at 48, is predicted to be about 50% of total bed capacity in the state. and the ICU bed need is predicted to be about 60% above bed capacity, or equivalent to about 200 beds. Now, the projections in the spring were a little bit more dire than we actually saw. I guess we're hoping sort of that will be the case here. But my point is that both on the medicine service and the intensive care services, they're pretty much at about their limits for what they can do right now. So we may be asked to help more. So there are a lot of parallels between our current situation and the 1918 influenza pandemic. On the left is a kind of a classic slide showing the three pandemic waves that were seen in the United Kingdom from 1918 to 1919, with the biggest peak of mortality occurring in the fall and winter months. Similarly, with COVID-19, we're in the middle of the third wave of this pandemic, and you'll see that we have three peaks, relatively distinct peaks, but the third peak is the worst one that we're seeing here, though again it is occurring in the sort of fall and early winter months. There's a projection that we'll have by April 1st at least 567,000 deaths. That the relative death toll in the United Kingdom 100 years ago was 228,000 deaths, or about 3 times the predicted death rate per population as we're seeing. It's kind of shocking, though, that given all the advances in medical care, that we're not able to improve very much more upon that. So here's a little history lesson about influenza in Seattle. So in late September 1918, already ill troops arrived from Philadelphia at Camp Lawton, which is now Discovery Park, and at Camp Lewis, of course now JV Joint Base Lewis McChord. And on October 3rd, the first death was reported from the UW Naval Training Station with about 700 cases. Fortunately, the leadership of the city reacted promptly. And on October 5th, the mayor, Ole Hansen, and public health officer, J.S. McBride, banned all public assemblies. And here's the headline from the Seattle Daily Times from that date. Here is a picture of a man standing outside a closed theater in Seattle. And it's interesting to note that the population made adjustments then as we have now. Here's an example. Here's an advertisement for Victrola. Why be without amusement? All theaters closed. So this is, I guess, the 1918 version of Netflix. The thing that concerned me a little bit when I saw this, though, too, is there are a lot of people in this picture. So I'm assuming that this couple is only invited their pandemic pod to their Victrola party. In 1918, differing mask use. Some were blunt than others. In New York, the slogan was "Better ridiculous than dead." You see a picture here of a street sweeper wearing a mask. Severe approach in London as well: wear a mask or go to jail. But of course, here in polite Seattle, it was the choice that was given was a little less severe. Wear a mask or walk, and you can see the streetcar conductor holding his hand out to the gentleman with the package who is attempting to enter the streetcar without a mask. Other accommodations were made. Here's an example of court being held in the open air in San Francisco in 1918. And this is the University of Montana version of remote learning physics class that was held at the football stadium. I don't know that I'd want to take a physics class at the outdoor football stadium in Missoula in the middle of winter, but so a bunch of hardy students and a professor there. There were consequences in 1918, as there have been now, for lack of following social distancing guidelines. Philadelphia is one particular example. Here's a slide from the Philadelphia Navy Yard, where the first case of the pandemic influenza was reported on August 27th. So it was clearly a problem then, and in fact affected our area as troops from Philadelphia probably brought the pandemic to Seattle. Yet, despite the pandemic occurring, they went ahead and held a Liberty Loan Parade on September 28th. It was still in the later stages of World War I, and so I'm sure people thought that that was important to do. But they had 200,000 spectators that had been estimated to line the streets of Seattle. And by mid-November, there were over 500,000 cases reported in the city. So there's an interesting paper from 12 years ago published in JAMA that looked at the effect of so-called non-pharmacologic interventions, school closures, public gathering bans, and other measures, and the relationship to excess deaths in 43 countries across the United States. And here are two examples from that. The first from St. Louis. The y-axis report shows the weekly excess deaths per 100,000 population. The arrow head is when the first mortality was reported. And then you can see below the school closures, the time at which the school closure were in effect, bans on public gathering were in effect, and then other measures in the case of St. Louis, restricting business hours and limiting the capacity of public transportation. Their total excess deaths were 358 per 100,000, and their total days of these non-pharmacologic interventions were 143. In contrast, Pittsburgh took much less severe or restrictive non-pharmacologic interventions, and they had a much higher death rate. Their total excess deaths were 807 per 100,000, and their total days of these non-pharmacologic interventions were 53. So I mentioned Philadelphia, New York, and Seattle, so I'll just show the data from those three cities as well as St. Louis. Here in the first column, report the date of the first case, which the first case was identified, and then the timing of the public health response in this paper is looked at relative to the date at which they really started to see an increase in mortality. And so you can see the time at which that occurred in each of these four cities. The public health responses were generally pretty quick. In New York, they actually started their non-pharmacologic interventions about 11 days before the start of the mortality increase. And then this next to last column shows the total days of NPI, 51, 73, 168, and 143. But you can see that there does appear to be a pretty reasonable correlation between the magnitude of excess deaths from pneumonia and influenza per 100,000 and the duration of NPI, also probably the timing of institution of the public health response. And actually both of those relationships were statistically significant across 43 cities. In 1918, they tried things that hadn't been proven, probably a prequel, if you will, to what we did with hydroxychloroquine in our country. On the left here is an example of an American soldier having his throat sprayed at Love Field in Dallas in 1918. But probably even more concerning was this practice. Soldiers were gargling, are shown here gargling with salt water to prevent influenza at Camp Dix, New Jersey. So I think we now recognize this to be an en masse aerosol generating procedure and definitely not ideal. So these are the latest guidelines from the NIH regarding exposure prophylaxis with hydroxychloroquine. And I'll show several slides from these guidelines, and they include ratings of recommendations, which go from strong, moderate to optional, and then the quality of evidence is graded as 1, 2, or 3, with 1 being the strongest, that there's at least 1 or more randomized trials with clinical outcomes and or validated laboratory endpoints. So these two are really categorized as expert opinion, but strong recommendations. The first based on 2 small randomized controlled trials of pre-exposure prophylaxis with hydroxychloroquine. The panel recommended against the use of any agents for pre-exposure prophylaxis, except in the context of a clinical trial. And similarly for post-exposure prophylaxis with hydroxychloroquine or any agent. There's 1 small randomized controlled trial and 1 cluster randomized trial. So the evidence is not strong in one direction or the other, but there's nothing that really rises to the level where we want to continue to expose patients to hydroxychloroquine, specifically for COVID-19. So moving on to inpatient care of patients with COVID-19. This, I just wanted to show pictures on this slide of how people in 1918 made similar accommodations to what have been done now. There were specialized COVID or influenza wards. Here's one at Walter Reed that's where patients are housed out on the balcony at the hospital. And then, we'd seen examples of emergency hospitals, particularly last spring, being set up to care for patients. And here's an example of one in Massachusetts, just outside of Boston. So it turns out that the medical therapies for COVID-19 that are proven really come down to 2. Those are dexamethasone and remdesivir. So for patients, the current recommendations from NIH, and these were just updated on December 3rd, are that patients who have COVID-19 but are not hospitalized should not receive steroids, should not receive remdesivir, and there's insufficient evidence for or against monoclonal antibodies, even though some high-profile individuals have received it, and some places are giving it to patients with COVID-19 who don't require hospitalization. If patients are hospitalized but they don't require supplemental oxygen, dexamethasone should not be used, and there's insufficient evidence for or against remdesivir. So it's really in people who are hospitalized, have SaO2 of less than 94%, and therefore require supplemental oxygen, in which these agents should be considered. So your choices are dexamethasone alone, remdesivir, or their combination. Here at the University of Washington, the combination, though it has the evidence isn't strong, it's really expert opinion, that is what's being used here. But if patients require high flow oxygen or non-invasive ventilation, then there's strong evidence for benefit from dexamethasone alone. Again, we tend to use the combination over here of dexamethasone plus remdesivir. And then finally, in people on mechanical ventilation or extracorporeal membrane oxygenator, dexamethasone has a very strong recommendation, and people should not be placed on remdesivir unless you're continuing the course of therapy. So the study demonstrating benefit of dexamethasone is the recovery trial from the United Kingdom. This was a trial in which 11,500 patients were enrolled from 176 UK hospitals. They were actually randomized to one of 5 different arms: standard care, dexamethasone, hydroxychloroquine, a combination of lopinavir, ritonavir, or erythromycin. So this paper reported the comparison of dexamethasone to standard of care. Simultaneously, they were randomized to standard care or convalescent plasma. That really hasn't worked out very well. And the primary endpoint was mortality at 28 days. And you can see that there was a dramatic difference in mortality depending on clinical status. Patients on mechanical ventilation had a mortality of 41%. Those requiring supplemental oxygen, 25%. And those not requiring oxygen was 13%. So very high mortality in the spring from COVID-19 in the UK. And on the right here, this table shows by patient group, the rate ratios for death and their 95% confidence intervals for dexamethasone versus placebo. So for those on mechanical ventilation, the benefit of dexamethasone was really quite strong, with a point estimate for mortality reduction of about 35%. For those requiring supplemental O2, there was about a 20% point estimate for mortality reduction. But for those not requiring supplemental oxygen, there was no evidence of benefit, possibly a trend towards harm. The major remdesivir trials, the ACT-1 trial sponsored by the NIH, in which 1,062 patients were enrolled with COVID-19 and evidence of lower respiratory tract disease by imaging or oxygen saturation. And patients in this trial were randomized to remdesivir or placebo for 10 days. The primary endpoint was time to recovery. And in remdesivir, it was significantly shorter at 10 days versus 15 days for placebo. There was a slight trend perhaps towards benefit in the remdesivir group with a hazard ratio of 0.73, but this really did not reach statistical significance as evidenced by the corresponding 95% confidence intervals. So now in this study, they reported recovery rate ratio. So the higher ratio is better. And there was really no benefit in people either on mechanical ventilation or ECMO, or those who required high flow nasal cannula, nor non-invasive ventilation. And so this is why there is some difference in the guidelines about the potential in our clinical practice about whether or not dexamethasone and placebo should be used in combination in those groups. So it was really the group of people who required a supplemental oxygen, did require supplemental oxygen, but not high flow nasal cannula or BiPAP, who had benefit in this study, increased likelihood of recovery. And there is actually even a statistically significant reduction in mortality of about 70%, though there are wide ranges in the confidence intervals, and this was not the primary endpoint of the study. So take that with a grain of salt. So in summary then, for corticosteroids, dexamethasone, strong indications in people requiring supplemental oxygen, 6 milligrams IV or PO daily for 10 days or until discharge. There's concern that there may be worse outcomes in patients who have co-infections with influenza. Fortunately, we haven't seen much co-infection with influenza, probably in part due to the non-pharmacologic interventions. And then for people at risk for strongyloides by virtue of their place of birth, residence, or travel for more than 6 months in a high-risk area, ivermectin is recommended, and testing for strongyloides is not recommended. They recommend just going ahead and treating because the side effects, risks of ivermectin are quite low and it's very inexpensive. In the rare cases where high-dose corticosteroids can't be used, they recommend stress dose hydrocortisone, and say consider remdesivir combination with a JAK1/2 inhibitor, baricitinib, but it's not our practice. The data for that baricitinib is weak, and it's not our practice here to use that. For remdesivir, it's 200 milligrams IV once, then 100 milligrams daily for 4 days or until discharge. They recommend daily CBC chemistries and particularly liver enzymes because hepatotoxicity is the major concern with this drug. And so if the ALT rises to 10 times above the upper limits of normal, you should stop the medication. In terms of concomitant medications, there's been a lot of controversial publications back in the spring about some of these, in particular ACE and ARBs, high-profile publications that required retraction. But there also has been concern about whether these might be harmful in patients with COVID-19 due to the virus's affinity for the ACE2 receptor. But the recommendation, strong expert opinion is that these drugs should be continued if they're previously prescribed for a standard indication. For corticosteroids, again, they recommend that people should be placed on dexamethasone if they're on chronic corticosteroids and on supplemental O2 or on mechanical ventilation. But for people who are on chronic corticosteroids, those should be continued if they're used for an underlying condition. And this includes inhaled corticosteroids for chronic obstructive pulmonary disease. And you should consider stress dose steroids. For patients who are pregnant, dexamethasone if they have a supplemental oxygen required, or mechanical ventilation. Encourage a maternal fetal medicine consult if you have a pregnant patient, definitely on your service. It is the practice here to also give remdesivir if they have a supplemental oxygen requirement. In terms of statins, they should be continued if previously prescribed, but they should not be prescribed specifically for treatment of COVID-19. And then finally, for non-steroidal anti-inflammatory drugs, they should be also continued if previously prescribed, but they note that as an antipyretic, they are equivalent to acetaminophen. So I think most of us would prefer to use acetaminophen in that case. There was a lot of talk, particularly last spring and early summer, about antithrombotic therapy in COVID-19, and the short answer is that we should only give antithrombotic therapies for standard indications. In terms of labs testing, D-dimer and fibrinogen, D-dimer in particular is strongly associated with a risk for death, but there's no data to support measurement of that marker specifically in COVID-19 because there's no evidence that treatment for an elevated D-dimer in the absence of a clinical disease has any benefit for patients. For people who are on chronic anticoagulant or antiplatelet therapies, probably most of our patients, those therapies should be continued for standard indications. And for treatment, use standard institutional non-COVID protocols. If diagnostic imaging is not possible due to concerns of equipment or lab exposure to patients, you should treat for incident or highly suspected event. Reasonable protocols are in place to allow imaging for these patients. And really you should use standard anticoagulant protocols for patients on ECMO or continuous renal replacement therapy. And in particular, some of these things that were tried or proposed should not be done regarding VTE prophylaxis and screening. You should not initiate antithrombotic, anticoagulant, or antiplatelet therapies for non-standard indications. You shouldn't discharge patients on VTE prophylaxis. And there's insufficient evidence for DVT screening based only on lab parameters, but of course, you should consider thromboembolic disease as a contributor if there's rapid deterioration, pulmonary, cardiac, neurologic, or localized loss of peripheral effusion, suggesting an arterial thrombus. So let's move on to critical care of patients with COVID-19. And I included this slide to show how people in Seattle and 19 healthcare workers were wearing masks in their congregate spaces. But I also wanted to show this to remind everybody that we should not be eating or drinking in the team rooms. There are a number of break rooms around the hospital that can be used for that, but it is the case that in our system, most of the healthcare worker to healthcare worker transmission has occurred in these settings, eating and drinking or aerosol generating procedures. So in terms of hemodynamics, they recommend dynamic methods to assess fluid response, that is following serial lactate levels or capillary refill time. I think a lot of our patients will end up just going ahead and putting in a central line. Balanced salt solutions such as lactated ringers are preferred for fluid resuscitation. And norepi is the first choice pressor as it is in standard sepsis management. Either vasopressin or epi could be used as a second agent, and they recommend an arterial line appropriately in everyone who's requiring intravenous pressors. If there's documented evidence of cardiac dysfunction or clinical hyperperfusion despite fluid resuscitation and norepinephrine, then they do recommend dobutamine. And Jim Kirkpatrick and the ECHO lab here have worked out protocols for safe performance of bedside echocardiography by our sonographers and people in whom this is cardiac dysfunction is suspected. And then if dexamethasone is contraindicated for some reason, then use their lower dose shock reversal steroids as are preferred over none. The recommendations against the use of albumin or hydroxyethyl starch for volume resuscitation, and a recommendation against dopamine either as the predominant pressor or the low-dose renal dopamine, which still is sometimes used, which has clearly been shown to be ineffective. For hypoxemia, despite conventional O2 therapy, there's really been a movement towards high-flow nasal cannula, which is preferred over BiPAP, and that is frequently used in our institution. However, you can use BiPAP, trial of BiPAP if high-flow nasal cannula is not available, and they don't have a indication for mechanical ventilation. But here, HFNC is available, so you should use that. And you could consider a trial of awake prone positioning, but there's a caveat with that, which will be coming up. And then finally, if intubation is believed to be necessary, you should perform that in a controlled setting to minimize viral transmission risk. They do recommend against awake prone positioning as a strategy to try to avoid intubation. And again, I think this follows along with this recommendation that if you think somebody's heading for intubation, you should just probably do that in a controlled setting. If people have ARDS, PDF ratio less than 300, they should have low tidal volume or lung protective ventilation with a tidal volume of 48 mLs per kilogram to protect against lung barotrauma. Target a plateau pressure of less than 30 centimeters of water. Recommend a conservative fluid strategy. I think it's always reasonable. And they recommend against inhaled NO, basically because there are other options, and there's not for pulmonary vasodilator, and it's really quite expensive. If they have moderate to severe ARDS, which is a PDF ratio less than 200, and require intubation, higher versus lower PEEP is preferred. You should try to put the patient in the prone position for 12 to 16 hours. Really nice protocols have been worked out by the nursing and respiratory staff here to accomplish that. And use neuromuscular blocking agents which are really necessary for lung protective ventilation and for patients with patient ventilator dysynchrony. For persistent hypoxemia, you should try recruiting maneuvers. That is optional, and you could consider also inhaled epoprostenol as well, though again, that's optional and not necessarily proven to be beneficial. Actually, for acute kidney injury, they prefer continuous renal replacement therapy, available here really only in the cardiac ICU. If that's not available, slow dialysis or slow continuous ultrafiltration with a standard hemodialysis machine should be used. They recommend against antimicrobials in the absence of a contraindication, and if they're started, you should reassess their use daily, as we do with quality safety checklist in the ICUs. And it's really for ECMO, though we have spent a lot of time trying to figure out who can get it, who should get it. There's frankly insufficient data to recommend either for or against ECMO for refractory hypoxemia and COVID-19. It's we certainly do offer it. VV ECMO is, venovenous ECMO is preferentially done at Harborview, and patients requiring VA ECMO are preferentially cared for here at Montlake. So starting to wrap up here, in 1918, it turns out that they had vaccines too, and here's an old photograph of Seattle men lining up to receive their influenza vaccines in November. There's some differences now. Those many cities like Seattle had placed great emphasis on a public vaccination campaign, but I'll point out that unfortunately vaccines at the time were useless. Ours that are currently available are have been shown convincingly to be highly efficacious. The other difference is that we have examples of women as well as men getting the vaccine here, as opposed to 1918. Two enthusiastic members of our faculty lined up quickly to get these. There's been some concern about whether or not the current vaccines will be effective against emerging genetic variants of the SARS-CoV-2 virus. There's a nice paper from Wednesday published in JAMA, which shows the phylogenetic tree of the SARS-CoV-2 viruses that have been isolated around the country. The one of concern is this one in dark orange, the B117 variant that appears to have a much higher affinity for the ACE2 receptor, and is really sweeping through southeastern England, UK, led to and now Europe, and has been found in the United States. The frequencies of the circulating lineages are shown in the bottom graph. Here's that B117 variant in the lower right corner in dark orange. But the authors of this paper, I think, reassuringly pointed out that the current vaccines provoke an immune response to the entire spike protein, and therefore they believe that there will be likely be effective prevention despite a few changes in antigenic sites of the virus, but that convalescent plasma, which has not really been shown to be particularly effective, may be even less effective. So here's a summary of the specific therapies, as well as some ongoing trials here at the University of Washington that you could consider enrolling patients in. And these are from the UW's ID treatment guidelines that are available on the website. So no therapies for patients who are not hospitalized, though there is an ongoing trial of monoclonal antibodies in patients who don't require hospitalization through the AIDS Clinical Trials Unit in Fred Hutch. No really therapies for people who require hospitalization but have an SpO2 of 94% or greater. And then, of course, for corticosteroids, anybody that requires O2 should get corticosteroids. We do give remdesivir to people who require supplemental O2 or high flow O2, but really not for ventilated or patients on ECMO unless they were already started on it. For convalescent plasma in these three groups, there is another trial, the Pacidon clinical trial is being conducted here. And for monoclonal antibodies, insufficient evidence. So the ID service screens for potential candidates for these trials, but definitely if you think you have somebody who might be a candidate for these trials, please reach out to the ID consult service. So in summary, non-pharmacologic interventions were and are effective in controlling pandemic respiratory viral illness. And thank you for continuing to observe these practices, especially in team rooms. We will continue to be called on to care for patients with COVID-19. Patients with COVID-19 with primary cardiac problems are cared for on all of our services, including the transplant service, because we're confident in the infection control practices that are in place in this institution. But because we're really reaching the limits of the medicine and critical care services, we are likely to be asked to care for these patients at an increasing pace over the next few months as our capacity permits. One plea is that particularly the medicine service here is really at their limit. So please don't request of them to transfer patients to medicine. We have had capacity, at least up at this point, to continue to care for those patients on medicine. And some groups of patients that with heart failure or controlled AFib, as examples, that we have typically, or syncope, who particularly placed on medicine, they've asked that we be willing to take those patients onto our services as our capacity permits. So I appreciate your help with that. The third point is the care of these patients is probably less complicated than we first thought. But the illness is severe. COVID-specific therapies are straightforward, that is really two. And conventional approaches to complications and prophylaxis are generally preferred. And finally, I want to thank you all for your courage and flexibility during this pandemic. We're not out of it yet, but I think we can see the light at the end of the tunnel. And I also want to especially thank you for your exceptional care of our patients as you have for many years. A few acknowledgements. Tiffany Chen and Carolyn Keller have a COVID primer that is used on the GIM service, and I've been allowed to share that with people if they're interested in it. Laura Evans from Pulmonary Critical Care Medicine has promised me a preprint of the upcoming COVID sepsis guidelines. They're soon to be published. Janelle Badulak has been a great collaborator in trying to modify the heart shock protocol, both so that we can care for patients with COVID, but also that patients with heart shock who can get access to VA ECMO if indicated on a fair and equitable basis. To Karen and Rose for their leadership, the clinical services and the fellowship, and also particularly for working really feverishly, the three of us, over a weekend in early April to develop our COVID plan. And then finally, to two groups, Heather Foster, Carrie Boom, Lisa Garrett, and Christine Riel and Husan Chung. Together we formed the sort of leadership team for inpatient services, and the creativity and flexibility of this group and trying to maintain staffing during this time has really been remarkable. And lastly, special thanks to Graham and Brenda Siddall, who really lovely people and had made, out of the blue, made a really generous contribution to support COVID research at the University of Washington. So thank you all. Before I take questions, I wanted to mention the passing and honor Greg Brown, who's a friend and colleague to many of us here. Greg died, excuse me, Greg died on Tuesday of complications of pneumonia, not COVID, at the age of 80. He received his bachelor's degree from MIT, his MD, PhD in biomechanical engineering at Hopkins, where he actually was intimately involved in the development of the intra-aortic balloon pump. He then went on to do internal medicine at Hopkins and UC San Diego, followed by a clinical associate, service as a clinical associate at NHLBI with Don Fry, where he studied arterial wall lipid diffusion. He came then to University of Washington for his cardiology fellowship, where he worked under Hal Dodge and developed quantitative angiography. He migrated to Los Angeles VA for 3 years as a clinical investigator, but returned in 1979 to the UW faculty for 33 years. He was actually the inaugural recipient of the Irvin Page Award from the HA. It was established investigator award from the HA as well. And he was a principal investigator on 3 landmark clinical trials of lipid-lowering therapy in atherosclerosis, FATS, HATS, and AIM-HI, all of which were published in the New England Journal of Medicine. In total, he had over 140 peer-reviewed publications. And in 1995, he was recognized by the NIH with their Clinical Science Achievement Award for his studies in cholesterol, metabolism, coronary regression, and plaque stabilization. So with that, thank you for your attention, and I'm happy to take any questions.